And when exactly he should be sent for a higher center? When do you suspect that something is going wrong? He is unlikely to recover and he needs an immediate attention by the specialist. Over to you, Soumya. Yes, the slides are visible.
So the last topic for today's discussion, that is when to refer a patient with acute hepatitis and when a family physician should refer to such a patient to higher center. So first, I'll be discussing about acute viral hepatitis. Worldwide, hepatitis B virus is the most common viral cause for severe acute liver injury and ALF. And it can be a de novo infection or a delta superinfection or reactivation in a patient previously known to have Hep B infection. However, vaccination, since the vaccination programs are successfully implemented, there is a significant drop in the incidence of hepatitis B virus cases and concomitantly a fall in ALF secondary to hepatitis B infection. Reactivation can happen in patients receiving a chemotherapy or immunosuppressive therapy for a malignant disease or a rheumatological diseases, and such patients have higher mortality than de novo infections. And less than 1% of patients with acute HAV will usually develop ALF. Acute hepatitis due to HEV are most frequently seen in patients who have traveled to endemic areas, and pregnant females are more prone to develop ALF secondary to acute hepatitis E. Hepatitis D virus alone, we don't usually get infection. It's usually a co-infection or superinfection with hepatitis B infection. And C, rarely we come across acute presentations. And other differential diagnoses for acute hepatitis are severe malaria, dengue, leptospirosis, sepsis, cholangitis, liver abscess, and drug toxicity. In our country, Hep E is causes the main etiology for development of severe acute hepatitis related liver failure. So these patients at the initial presentation in any family physician should assess for the disease severity by getting a complete liver function test, coagulopathy evaluation, renal functions consisting of urea, creatinine, and hourly urine output monitoring, arterial blood gas analysis and analysis of lactate levels and arterial ammonia to look for the signs of early signs of hepatic encephalopathy, and etiological workup consisting of a toxicological screen, especially where paracetamol is available over the counter. There is a high risk of suicidal attempts using paracetamol, and other drug-induced liver injuries are common in Indian scenario. So toxicology screen should be done in these patients. Virological screening for hepatotropic viruses and other rare viral infections such as herpes simplex, varicella zoster, cytomegalovirus, and Epstein-Barr virus should be screened for. And rarely autoimmune hepatitis can cause severe acute hepatitis and acute liver failure. Serological markers should be sent for the analysis of autoimmune hepatitis. And these patients mainly require referral to a tertiary care center for the whenever there is evidence of multi-organ or end-organ related complication as a consequence of acute liver failure, may it be neurological causing cerebral edema and encephalopathy, ARDS, acute renal failure, metabolic complications like dyselectrolytemia, recurrent hypoglycemia. Secondary infections due to bacteria or fungal infections can be there. Hemodynamic compromise can happen in these patients. So whenever there is an evidence of end organ failure as a consequence of ALF, these patients require judicious monitoring. So the development of one or more of the following, we should suspect impending acute severe hepatitis or acute liver failure when there is a severe or persistent nausea and vomiting, when there is a change in the mental status, like excessive sleepiness, irritability, agitation, disorientation, confusion, or abnormal behavior, or decreased level of consciousness, whenever there is episodes of spontaneous bleeding, in occurrence of recurrent episodes of hypoglycemia, fever that is not possible to be managed pharmacologically or by tepid sponging, severe dehydration or INR above 1.5. In any patient with hepatic encephalopathy, transfer to an appropriate level of care, that is, wherever a critical care unit is available at the first symptoms of mental alterations. Do not wait for it to settle. As soon as the patient develops first episode of a mental status alteration, refer them immediately. These patients, until the transfer, should be nursed in a quiet surrounding with a head of bed elevated to more than 30 degree and head should be in the neutral position. And before transferring, intubate and ventilate if necessary. And if there is more than grade 3 hepatic encephalopathy, sedate these patients too. And before transfer, ensure adequate volume replenishment and normalization of biochemical various as much as possible. The referral should be to a tertiary care unit and preferably where the transplantation facility is available. So coming to how to transport these patients, and these patients should be transported with a trained healthcare personnel. There should be a detailed discussion between the transferring team and the receiving physician's team, which is essential before the transfer. In the scenario of an evolving hepatic encephalopathy or patient worsening sensorium, these patients should be intubated and sedated to ensure a controlled and safe transfer. Fluid replenishment and resuscitation of volume resuscitation and maintaining of normoglycemia should be ensured during the transfer. Vasopressors, if required, should be administered during transfer. Mannitol in cases of features of raised ICP should be administered during transit. And consider any patients of acute hepatitis without evidence or even without evidence of severe liver injury or an impending liver failure, consider transfer under the following special circumstances: any underlying cirrhosis or previously known hepatitis, chronic hepatitis B or C infection, any pregnant females, people living with HIV or a compromised status, underlying autoimmune hepatitis, patients present already having comorbidities such as cardiac or renal dysfunction, and patients with malignancies receiving cytotoxic therapies. These patients are known to have a protracted course of acute hepatitis and other end organ damages. So consider transfer of these patients at the earliest in case of acute hepatitis. Thank you.
Thank you. Thank you very much. I think we have